And Gary came down and goes, what is going on? They said, I've got videos going on. And even now, push something and I'm sitting in the garage door. I'm in a taxi. It looks like it's about
Yes. Surgery on the Islander is
times I didn't think it was like, I didn't have times that you have glasses.
And there's a hand.
Yeah.
So if you're going to walk away, when you feel like you want to move, you don't have a wireless, you have a hand mic, it works better here, take it with you. Because once you leave the podium, it won't work. But you're welcome to move, you're welcome to move anywhere.
Good afternoon. I'm really excited to be here. This is our RSDSA's adopted state. First time we've done something in Connecticut. We were birthed, I don't know if you know, in long time ago in 1984 in Haddonfield, New Jersey, which is a gorgeous suburb of Philadelphia, and it is just at night, everyone has candles in their windows. It's really Victorian, it's gorgeous. And two moms, their children developed CRPS, and they went on a search, as too often people with CRPS search for answers, search for docs that know each other, and they discovered Robert Schwartzman, who was at Jefferson in Philadelphia at that time, and he convinced them to start an organization. And so 30-something years later, we're here today, and we're real excited. So it's my honor to serve as RSDSA's Executive Vice President and Director. And on behalf of RSD's Board of Directors, our staff and volunteers, I welcome you today. We're really excited in this time of Advent, time of Hanukkah, and time of Kwanzaa. It's so exciting that people take time out of their busy lives to come. And I just want to encourage people that we asked that people wear name tags. If people have a red name tag, that means they have the syndrome. Blue is that someone is a caretaker. In brown, if they have that, they're a healthcare professional. A number of our board of directors people have come today. I would like to just give a shout out to Hank and Mary Beth Ludington. They're our co-presidents. And Peter Moskowitz is in the back with a great bow tie. Peter's the chair of our board of directors. Today's conference will be videotaped, edited, and posted on our website. We have 141 videos there, so you don't have to catch everything. Right after the conference, we're going to put our PowerPoints up on our education tab on our website, and the videos will be edited hopefully within 60 days. I want to highlight today, before our program begins, about a number of our awareness and programmatic initiatives. 3 years ago, RSDSA, with Andrea Jenkins, whose son had died by an accidental overdose, we started a patient assistance fund. It's called the Brad Jenkins Patient Assistance Fund. And over the last 3.5 years, we've given over $50,000 in patient assistance to people whose utilities might be in danger of being shut off, people who can't pay security deposits, need some extra dollars for rent. Sometimes we help with co-pays for medicine, and also sometimes travel to go see an out-of-state doc. So just an FYI, it's a 3-page application. It just asks documentation that someone has CRPS. It's based on income, and would love if you know someone who needs help to just do that. 2 years ago, in conjunction with the American Academy of Integrative Pain Management, we filmed Dr. Phil Getson, who's a wonderful family doc with a special interest in CRPS. We filmed him, and there's 2 courses that are free, 1-hour accredited courses for docs, nurses, and psychologists, and we have the flyer in your bag. So I really encourage you to really give that to some members of your healthcare team. In 2 years, we've only had less than 250 people take that course. So that's a tragedy, and we really want to really promulgate that. And right now, we're in the process of accrediting a course with Dr. Elliot Crane, who is a premier pain specialist in Stanford's Children's. And that's going to be like an hour course on pediatric CRPS. And thus far, after we filmed him talking about diagnosis and treatment, we filmed 6 little vignettes about children in schools and how do you work with a doctor who may not know about CRPS, and how do you kind of decipher that all these informations about these marvelous innovative treatments and cures that are on the internet. And so even though it's tailored for parents and children, it's on our YouTube channel, and it's kind of some really good information for everybody. And I also wanted to introduce you to Penny Pig, right here. For the last 3 years, our organization with 3 other organizations, US Pain Foundation, the Coalition Against Pediatric Pain, and Rock Out RSD, have sponsored a week for children in pain in Kentucky. And if you've never seen it, it's profiled. Some of the pictures are in our current newsletter. And when you see the pictures, it's like a college campus. It's gorgeous. And children from all over the United States, and some have actually come from abroad to spend a week with other children in pain. It's not specifically for people with CRPS, but here's kids that have been socially isolated and maybe even homeschooled, and they come for a week to have fun. And it's cookouts, it's canoeing, it's fishing. It's one of the best things we do, and it was really the brainchild of one of our marvelous board members, Sue Pinkham. We have a flyer that for the last 5 or 6 years we've been doing a 20-year study. There's been no really long-term studies of what's health's impact on people with CRPS. So RSDSA has started, with the help of the Brodsky Family Foundation, a 20-year study. And so I encourage you, if you have the syndrome, to take the flyer. It's on our registration page, and that sign up for it. We're in the process now of looking at, do we have to wait for 20 years? Can we break it open at 10 years? Because that's some valuable data to look at. How does CRPS affect someone's overall health? How many people in this audience have never met another person with CRPS today? A couple? Okay. Well, the job of today is really to break out of your comfort zone, to really reach out to other ones, and to really meet other people and build that support network that's necessary to survive this illness and to thrive with it. And sometimes in our conferences, we've done them all over the United States, and people build lifelong relationships. So please, I encourage that. And I wanted to just give a highlight to 2 individuals. We're building an advisory committee, and 2 people have flown across the country today. And Amanda Ashley, and she's a wonderful healthcare professional from Oregon, and she has a practitioner of something called the lightning process. And there's a flyer out there. But Amanda, thank you. And hopefully she'll see some snow tomorrow. And Tamara Stern, are you here? Ah, right here. And she's a marvelous financial planner from Northern California with a young adult with CRPS, and she's really been excited about helping us and really help how can we get the word out early about children and teens with CRPS. Finally, I just wanted to show you something that all over the United States, we're lucky enough to have people who give back. And we have a program called HUGS, H-U-G-S. And Jeannie Quackenbush from North Carolina, to keep her hands active, she crochets this. and it's a hug. And so sometimes when one of our staff people or myself will hear of someone having a real hard time, that we'll mail this out to them, and with a little letter saying, we just knew you wanted a hug. So if you know anyone in the community who might not be here, I really want to encourage that. And I wanted to know, may I give anyone a hug today? Don't be bashful. I don't want to bring it back. Okay, see me later, okay? I love giving hugs. And I just want to end with a quote before I introduce our first speaker. That it's a quote that guides me and it guides our SDSA. There's not always a solution to suffering, but there's always a positive response. Today is our positive response. So our first speaker is going to be Dr. Brian Snyder, and Richard Allen, who's his practice manager, is going to introduce him.
Hi, thanks for joining us today. My name is Richard Van Allen. I have the privilege of working for the doctors at NSPC Brain and Spine Surgery on Long Island in New York. One of our surgeons and partners, Brian Snyder, will be opening today's program with a new treatment option for patients with CRPS. He has done more DRG stimulation implants on Long Island than anyone else, so I think he'll share some important insights with all of you today. Thanks again for joining us. Thanks to Jim and the group here in Connecticut who have clearly made such a difference in this community.
Thank you, guys. Usually I like to speak last because I don't want people to think that this is the first line treatment. So it's nice to kind of hear everything and evolve to that. Quite honestly, I appreciate the accommodation. My daughter's dancing in the Nutcracker later, so I kind of need to jet out. But I've been taking care of patients with CRPS since the sort of advent of my practice, and there are a lot of treatment options. And I think the goal for today isn't to teach you everything about dorsal root ganglion stimulation. It's just to say there's some new stuff out there. It's very cool. It works very well, and there should be some new hope too. I've done a lot of this. I've actually done the most on the entire Northeast of this procedure thus far, and there are days where it even wows me with how effective it is. Hopefully this is going to advance my slides. It is. Good. So I don't want to teach you everything about CRPS. You probably know a lot more than I do at this time about it, but again, this was originally called causalgia, then it was called reflex sympathetic dystrophy, now we have CRPS 1 and 2, but again, it's a chronic pain condition, and it's characterized by continuing, spontaneous, or evoked regional pain, and it's typically disproportionate in time or degree to the course of pain in any sort of normal injury. In fact, patients will develop this with almost scant, if any, recollection of an injury at times, which can be a confounding factor in diagnosis. And then obviously there's typically a distal predominance, especially early on in the disease, and there can be abnormal sensory, motor, edema, trophic changes, etc. So first described 150 years ago. Again, the exact origin and how it develops is still somewhat disputed. So despite that we're getting better and better treatments, there's a fair amount of this we still have to scratch our heads about ourselves. But again, we're understanding more and more. And again, this occurs between 5 and 26 per 100,000 person years in the population. So while it's uncommon or rare, it is not extraordinarily so. So none of you are alone. There are other people suffering, and there are better treatments all the time. And you know, we as physicians are listening. So again, how does it happen? Well, typically there's some sort of insult leading to some sort of nerve injury, and then a cascade of events occurs. And again, part of the reason I like to speak later is that this is really not my focus. I tend to see people later in this, but you all know what occurs, but we can have both its central nervous system and the peripheral nervous system become sensitized. We get alteration of sympathetic nerves as well, and there are a whole host of changes that occur in the body due to that. So again, why is it different than other pain syndromes? Well, we have significant signs frequently as well as symptoms, right? So what are symptoms? Symptoms are what a patient complains about or what they're experiencing, and signs are things we can objectively observe. So many pains don't have corresponding signs, but we can have that frequently with CRPS, right? We can see edema, we can see changes in the skin color, we can see changes in the temperature, changes in the hair pattern, changes in the musculature, etc. Again, clues that this may be the disease involved, and also things we can look for to suggest whether interventions may be helpful. And so, again, unfortunately, what happens frequently if intervention is not accomplished or if it is unsuccessful is that the disease can progress, and it can progress from a relatively acute phase, right, where this is very early in, to a sort of subacute phase, and then to a chronic phase, right? And the disease can both progress locally as well as can spread, and that can be very, very scary and increasingly disabling to a patient. And so there's obviously a lot of treatments, and again, I'm not going to touch on all of these because they are somewhat out of my wheelhouse, but early on, patients want to try to restore function to the limb. You'll see pain management doctors. They may try blocks. They're certainly going to try medications. There's psychotherapy and cognitive behavioral therapies that can be involved too, occupational, physical therapy, and then at some point in time, if these things are inadequate, we're going to think about some nerve stimulation or neuromodulation to treat this disease as well. But it takes a team, right? It's not any one of these things that's usually a magic bullet. Unfortunately, it takes a village, as they say, right? So, ultimately, if those things were to fail, if it was more than about a year and a half ago, the thing we would think about is spinal cord stimulation. And I don't want the take-home message to be that spinal cord stimulation is bad or poor. It's just not right now what I would say is the first-line treatment in terms of neuromodulation. But spinal cord stimulation is effective. So this graph basically shows VAS score. That's the visual analog scale. That's those little faces if you have to fill out. That's one's happy, and they get less and less happy. I guess they're emoji-like faces, right? Before emojis existed. And this is looking over time, and what you can see is, so this is PT alone, and this is spinal cord stim plus PT. You can see that even physical therapy results in some amount of improvement, but it's a pretty negligible amount. Spinal cord stim initially is very effective, and again, over time, a little loss of efficacy. Better than nothing, but unfortunately not great. And this is in a population, though, of course, so there will be some patients that do remarkably well, and unfortunately, though, there are some that are less responders. But spinal cord stim is still a decent thing. So what's this new thing? So DRG stimulation, despite that I'm standing up here saying it's so new, it's been done in Australia, England, New Zealand for almost a decade, and the FDA, the way it works these days, is glacial in their pace of approval. So finally we're doing this, and I've been doing DRG stim for a little over a year. And what is the DRG? Well, it's this little area on the nerve right before it enters completely into the spine, and this is actually the nerve body. So all of this is the projection or the axon, and all of this going all the way up into the brainstem is the same, but this little spot, little different, better target. And those are the main sensory nerve bodies. So the DRG take-home message, it's a different area, so it responds differently. So it's different in structure. It's this thing called pseudo-unipolar. It's different in function. It's organized and selective. It makes it easier for us to find and target, and it behaves differently with response to stimulation. Not much spinal fluid around there. What does that mean? Less electricity, less issues, for those of you that maybe heard about or experienced spinal cord stim, less issues with movement affecting stimulation. This is, again, in contrast. So this is the spinal cord, where you imagine if you put an electrode here, it pretty much, electricity spreads like the sun. You're gonna get a large area, right? So very hard to tease out a smaller area, RSD in your foot, in your hand, etc. So why are we gonna target this area again? The science makes sense. It's in a predictable location, much more so than spinal cord stim. Again, if someone had spinal cord stim here a couple years ago, certainly, maybe the doctor would wake you up. Do you feel the tingling, buzzing, move the wire, keep doing that. We really don't need to do that in this situation. Less spinal fluid, so we can put the wire very close to the area, use much less electricity, and the motor nerve fiber isn't right there. So we also run into less issues where some people would have a little muscle contraction or other things like that. So again, spinal cord stim, hard to do anything but that. DRG, easy to do that sort of thing. Just put an electrode here and here. And it works. I mean, most importantly, again, it works. Again, we can interfere both with the sensory part, and by interfering here, we're going to interfere frequently with the sympathetic outflow. So we'll see reversal again of the signs and the symptoms. And we can see it objectively too, which is pretty cool. Sometimes, once in a while, it works very quick. Like you'll see this in the recovery room. That's not universal. Some patients will take time, but I've seen patients where the color, at least, if not the edema, will change in minutes of stimulation. So again, problems with spinal cord stim, not that we're just comparing it to that, but that was the sort of cutting edge for a while, is it's unstable, leads move more frequently, changes with position, it's nonspecific, and it uses a lot of energy, as I said. And this is what's addressed with DRG. There's less spinal fluid, there's separation of the nerve fibers, and there's limited spinal fluid, so less. So early studies looked at this, and again, this is a small case series of patients, and they looked at them for a year, and again, that same visual analog scale, and so at least short term, this study demonstrates significantly better efficacy than when we were looking, say, at spinal cord stim. And so then there was, again, this has already been approved outside of the States, but then that led to the pivotal study in America comparing DRG again to spinal cord stim. And why are we comparing it to spinal cord stim? These are all patients that had failed everything else. So you don't want to compare it to, say, doing nothing, because, well, we know already that there are things that are better than doing nothing. So that at this point in time, these are patients that had failed best medical management, that were not felt to be able to, again, they were patients that had chronic intractable pain, CRPS, significant pain on visual analog scale. Everything else had to be stable though, right? You can't do a study on someone if they're changing medications all the time, because if a new medication worked, you wouldn't know what the result was. But anyway, again, the two groups were similar, and we were looking for at least 50% pain relief in the area of pain. And then we were also looking that there wasn't other problems with stimulation. And again, this is compared to spinal cord stim at 3 months and 12 months, and again, a dramatic improvement. And again, this is not visual analog scale. This is how many patients improved greater than 50% pain relief. So 93 and 86% of the year. And again, we can look at it this way, 80% visual analog scale, and again, we see that in this subset, DRG is much better at targeting just the right area, again, almost everybody. And then we can look at all sorts of other measures. So again, this SF36 is sort of your general functioning. So it's better than spinal cord stim, and rightfully they could have included what the natural result would be, and that's unfortunately those would be even lower numbers. And it's better in terms of this POMS, which is the different pain psychiatric kind of issues that occur in patients, and it's also better in the sort of pain scale. So not only does it work, And not only does it improve pain, it improves everything in those patients' lives. So really, in conclusion, and then if there's a minute or two, I'm not sure what there is, but I'm happy to take a question or two. But this is, in America, we can only say the 12-month data supports this. But in reality, the 5, 6, 7, 8-year data outside of America does not show any loss of efficacy over time and is remarkable, really. And in my experience thus far, this is a game changer for those patients that nothing else has worked for. It's really, it's remarkable. So again, we have better pain relief, and it's sustained. It still works. It's easier to target the right area. It's also, I should say, it's typically paresthesia-free. So this sort of stimulation, you don't feel anything, typically. There's no buzzing or tingling associated with it beyond when we adjust the electrode. And it improves quality of life and function. So it's not just going to treat the pain. It makes everything a little bit better. So thank you. I'm happy if there's a minute or two to take some questions. If there's not a minute or two, I'm happy to take them. Okay, so I'm gonna, whoever I see, I'll just point to who I see, but if there are other people, scream out.
Just a quick question.
Sure.
So it is an implant.
So this is surgery. It is an implant. It's done in 2 parts. There's a trial which involves percutaneous or sort of non-cutting needles in the back, steer some wires into place, wires coming out of the back attached to an outside battery pack, and you test it for about a week. Not helping, can take those wires out in the office. Helping, repeat the procedure, permanent wires, pacemaker for the nerves for pain inside the body. Correct. Yes? So have I had any experience with, yes, I've taken care of many patients like that. Do I have significant experience yet with DRG in a patient with entire body CRPS? No. But I do have experience with patients with at least mirror symptoms on the other side, or at least significant spreading. And in general, in these patients that are successful, these symptoms not only abate in the targeted area, so we would start where the RSD started, or the CRPS started, but it tends to cause reduction and or resolution of symptoms in the areas it had spread to. So it would not be unreasonable at all to try it in someone in that situation. Obviously, the volume of those patients is less, so I can't say I've put it in anyone like that. But I put it in patients where the whole leg and the other leg is affected. You target one foot with a couple electrodes, and over time, first the pain in that area starts to resolve, the mirror symptoms resolve, and the other areas tend to improve too. Yes? Sure. So the procedure should be covered by insurance, usually is covered by insurance. There can be occasional issues which, our billing people or wherever you did this would work through, where, say, if you had, because the code is identical to spinal cord stim, and once in a while they'll catch it and say, oh, they already had this procedure or something like that. But this is FDA approved, covered under CMS, so it's usually just a matter of having insurance people listen rather than just sort of, square peg, square hole kind of thing. But it should be covered in general, yes. For CRPS at least. So it could be done anywhere. I routinely do this stuff in a surgery center where you have to go home the same day, in fact. Yes? Risks of the procedure. So, unfortunately, if you ask a neurosurgeon what the risks of something they're going to do are, the list is very long. So a lot of things could happen. I will tell you those risks are extraordinarily small, right? So the biggest risks would still be hardware-related issues. The wires still can move. The wires can break. You can get a post-operative infection. You could get an issue with bleeding after surgery that could lead to a neurologic deficit. I've never seen that happen. And there's always a risk of spinal fluid leak, headache, et cetera, on placement of the electrodes. Yes, sir?
How long have most of your patients had the disease that you're working
You know, I think that that's somewhat varied, but certainly people I'm seeing would have had it a longer period of time than, say, your local pain management doctor, because they would at least have needed to exhaust conservative therapy. But there are patients I see that have been misdiagnosed, mismanaged for many years, and I'll see them. There are other people that have good care and unfortunately will kind of progress through everything within 8, 10, 12 months. Yes, in the back, in the middle. Well, the answer to that question is not fully clear yet because of the longevity of implant. What I would tell you is that in general, when we think about neuromodulation as a whole, we believe if you turn the device off, over time, the symptoms will return. There is small amount of anecdotal evidence that in some number of these patients, and sort of neuroplasticity changes in the nervous system anyway, that stimulation could cause cure, which could mean in theory one could explant it, but most patients and or doctors that have successful results are not usually too interested in tempting fate by turning it off to see what will happen, in all honesty. Changing the pacemaker, which is the only thing that would need to do chronically, is every 6, 7, 8 years, depending on electricity, and that's pretty minor and well tolerated.
Yes, you may have covered this because I came in a few minutes late. What is known as to known etiologies for CRPS?
So I actually didn't really cover it because it's a little bit out of my wheelhouse. In general, though, somehow a normal injury, shall we say, or whatever, some normal type of event leads to a disproportionate cascade of both peripheral and central sensitization, and as well the sympathetic nervous system being involved. But I'm not really, I'm like just the plumber that puts the wires in a bit. So I don't want to tell you what the neuroscientists are thinking about how this disease exists. I think that's all the time. I'll stay at least a couple minutes if anyone has any questions. But thank you so much, and there really is a lot of hope for you guys. My pleasure.
Thank you, Dr. Snyder. And Mr. Van Allen will be at the exhibit table in the lobby. I'm very excited about our next speaker, Dr. Data, who's at the Center for Pain Management in Hackensack, New Jersey. A number of years ago, we were at our Achilles Walk, which was a major fundraising walk in Central Park, and I saw this group with all these yellow T-shirts, and they were unbelievable. And I said, who are you with? And they said, Dr. Data, of course. And I've gotten to know him over the last couple years, and there's really a couple comprehensive go-to guys in New England that I think of all the time. One is Pradeep Chopra in Pawtucket, Rhode Island, and the other one is Dr. Data in Hackensack. And basically, at any time, he's really a patient advocate. He just is not any particular modality. He works with the interdisciplinary care, not just in his office, but he refers out. And I think it's a treat that we've got him today, and Dr. Data.
Hi, good afternoon. James, thanks so much. That was a nice introduction. Now, normally we have the sequence where we start with saying what is complex regional pain syndrome. But Dr. Schneider had to get out, so we'll kind of excuse him on that option over there. But so just out of sheer, raise your hands, how many of you are medical professionals here? So it's a smattering of them. So this is going to be something that I want that's going to have some medical information over there, but also for patients to understand what it is. And please feel free to ask questions, because I think knowledge is what makes us all understand or be able to cope with this process better. It's the ignorance of not knowing what it is, and it's just not the patients. I promise you that ignorance among us as medical professionals is so huge that I wish we could explain this to people and saying it's not all in the head, even though it is in your head. I mean, if you're a patient, you know it is in your head. So, seriously. Anyways, I work as a consultant with Quest Diagnostics. Other than that, there's nothing there. So this is what Dr. Schneider said. This is something that is interesting, that it was in 1872 or something. That's when they first made a recording and reporting of this whole process over there. And since then, it's been going on. Now, it was categorized as being a rare disease process. So a rare disease process means that there are less than 200,000 patients with this condition over there. So we are quite special if you think in those terms. Now, what is it? And these pieces of information are going to coming up, they'll keep coming up to you over and over again. But essentially, it's an inflammatory and neuropathic pain process which affects the autonomic nervous system. What is the autonomic nervous system? So there are basically three types of nervous systems in your body. One is the motor, so what makes your hands go up and down. The second is the sensory, where you feel the touch and the pain and stuff like that. And the autonomic is the third one, which is where things like your heart and all that is beating by itself when you start sweating and all that. So it affects that process. And it is that reason why you see all these symptoms of swelling and color changes and all that is what you get to see. Now, for convenience purposes, they made this categorization as type 1 and type 2, but at the end of the day, it doesn't really matter whether you have a type 1 process or a type 2 process. The treatment options for both those are the same. So you can say what you want to, but at the end of the day, if you come to me, it's CRPS, it doesn't matter 1 or 2. Now, what is the epidemiology in this condition? That's the mean age. Now, I see, and I spoke to a few of you over here who have had children who have had CRPS. I've had that too, and I'm not advocating that I'm a pediatric specialist in any way. I usually only work with adults. Now, why you have such an incredible difference, 4-to-1, female to male ratio, I do not know the answer to that process over there. If it is something to do with an immune problem, maybe so, because we know that immune disease processes affect women more than they affect men. And there is an immune process going on in CRPS. So this is the same numbers that Dr. Schneider mentioned about the upper limb. Far more commonly seen in the upper limb than it is in the lower limb. And these are some of the conditions that we find CRPS associated with. Actually, I'm working with one of the surgeons, an orthopedic surgeon who's had knee surgery, and I just was working with him today, and he's got CRPS. And that is post-surgery. Now, this is a medical slide, but I mean, you guys are all patients over here, and all I can say is that I think that the fact that you're associated with, James and his association is really good, because if you look up his webpage, his webpage looks like a medical webpage. It's not like a advocacy page. It's got so much information in that I tell all my patients, I said, go back and read from there and then come back and tell me what you learned, because I may have missed something over there which I didn't keep up with what James is keeping up with. So this is, even though it's a medical process, but it is something that you look at and you say, hey, these things happen to people. Having a simple thing like lymphedema, you might have lymphedema and you go to the emergency room and all that they will tell you is that you have swelling in the leg, and go find out what are the reasons for swelling in the leg. But it is because of the fact that you've read about it, you know what it is, and you're going to tell them this is not the usual swelling, it is related to CRPS, and nobody knows what CRPS in the emergency room is. Very few people do. So you have that to worry about. Now, these were these things that they made a mention about as to how would you make a diagnosis. Again, it's a medical slide. Initially, there was the IASP criteria, and then this came up, which is the far more solid criteria that we use. It's called the Budapest criteria. They all kind of went to Budapest, had a party, and they said, okay, let's kind of come up with something, how to kind of come up. This was the thing. No, they did have a party. What do you mean? But anyway. But this was the entire thing over there, and they said that you have to have one of the three of the following 4 categories and at least one sign in this process for the evaluation: sensory motor, pseudomotor, motor, over there. It has helped us to say, if I can find a patient in which I can see all these things coming through, then to make a diagnosis becomes easier. Now, there isn't any particular test, and I'll tell you that also, but there isn't any particular test that we do in that we can make a diagnosis of CRPS, so people come around and tell you, oh, you can do this and you can do that. There is nothing definite. You know, if you take a plain x-ray and you have a fractured bone and your bone is broken over there, the x-ray shows you it's a broken bone, and you say, I have a broken bone. There is nothing like that that you get to see which says, yes, this is happening over there, so you have complex regional pain syndrome. It doesn't happen. So that's the reason why getting to know what the criteria are, which is the Budapest criteria, has allowed for us to say we can, with an increasing amount of certainty, say, yes, we can make this diagnosis. What is the pathophysiology? I don't know. And this is an important thing for you to understand, that when a doctor says, I don't know, it's not because he's trying to be fresh or anything at all, because we don't know what is it that happens in CRPS. We know there are certain things that happen, but what is the actual process, we just don't know. But there's mention about small fiber neuropathy, there's mention about the sympathetic system that I talked about, inflammation and central sensitization. The central sensitization is something that is there, and this is part of the reason why I tell people that if you go to the emergency room, the only reason I'm making a mention about emergency room is because that's a place that you go to, and somebody says, you know, it's all in the head. It is truly in your head. And when I mean by truly in your head, it is because of this understanding that there is central sensitization, and I'll make a mention about this a little later. You saw this slide, so I'm not going to make a mention about this, but essentially tells you what happens over there. You have an injury, you get central sensitization, and this whole process keeps going up and up. There are all these different inflammatory modulators that are coming through, so this is a complicated slide. So these are the manifestations that you get to see. Now, I am sure if you look through these manifestations over here, you're going to raise your hand up and say, I have that. How many of you have pain? Everybody's got pain. We all get pain. I am in pain right now, in my back. I was sitting in the car for a while. It's hurting. But it's not disproportionate to what I would expect. That is the part that you really remember over here. It is disproportionate to the intensity of the event that happened over there. This is what is different about the pain that you normally have. Okay, it is increased in the limb in a dependent position. Have you seen that? Every often you will tell everybody, you know what, I like to lie in bed and put my leg up because I feel more comfort in that process. So you think about all these symptoms and say, hey, that's pain. Hyperesthesia. How often have you seen somebody walking into your office and you say, don't touch my hand, because they don't want you to touch that hand because that hand is so hypersensitive? That is the hyperesthesia that you have. So thermal. People have significant peripheral sensitization over there, so that when you go to shower, they'll put a leg out over there and shower. They don't want the cold water or the hot water to touch the leg. That is that process over there that happens. Weakness. This happens all the time. People come in over there, they start having to walk abnormally over there, and they start getting weakness in the legs, weakness in the muscles over there. Range of motion. Range of motion is reduced, and this is reduced because you're trying to protect your hand or you protect your leg over there. You protect your ankle. Tremors, you see these people over there? Have you seen that? That's myoclonus and dystonia are these abnormal movements that you get to see. Peripheral edema, very, very common. It happens in more than 80% of the people over there. Temperature and color variations, more than half the patients happen over there. And sweating abnormalities. How many of you have had this process over there where you're sitting and suddenly start sweating in half the body? I have this patient who comes to me and she tells me, she said she sits in the office and at work and suddenly half her body is sweating, and everybody comes around and looks at her and says, what's the matter? I said, I don't know. Have you seen that? Have you had that happen to you? So what are the signs that you see which are trophic signs and symptoms? Abnormal hair growth. People come and tell you that their nails are falling off faster, their hair loss is happening over there, atrophy of the skin, muscle atrophy, fairly common, and contractures. Osteoporosis happens, especially in the chronic stages. This is one thing that you get to see. This is one investigation that may be useful. It's not diagnostic, but useful to say, listen, are you getting osteoporotic? Because if you start having that happen, you start to treat the patients more aggressively. All right, so let's come to management guidelines. This is what we really are interested in. I mean, how do you manage the process over there? There is no one way to make a diagnosis other than what we talked about, the Budapest criteria over there. But the basic goal that you're looking at is to try and control the pain and maintain function. If you can maintain function for any patient with CRPS, they are delighted. It is because that lack of function, so they can't go to work. Once they can't go to work, there are all these social issues that happen over there. You got a 40-year-old female, can't go to work. She loses her economic freedom over there. It's a huge process. So trying to maintain function, that should be our basic control, is how do you control pain and how do you manage function. Functional improvement, this can happen long before pain control can happen. So suddenly you see that they are doing well over there, the patients get around, they're walking around, but they're still complaining about a pain scale of 8 or 10. Now, like I said, there are no practice guidelines, no specific tests, no cure for the condition, but we should hopefully be able to control it and keep it under some kind of remission. Symptom remissions may happen with variable durations. Early intervention results in best results. I was just talking to somebody, that I'm taking care of this doctor over there. He's an orthopedic surgeon, had knee surgery. He called me up and he said, I need your help. I said, what's happened? He said, I'm having such uncontrolled pain. In 3 months, he's had 4 knee surgeries. Now he's got crips on his leg. And this is a gentleman who does total joint surgeries, so he stands and works. When he came to my office, he couldn't sit. He said, I cannot sit. So what did I do? I immediately started, I said, I'm going to set you up and start doing some sympathetic plexus blocks. So I've done 3 of them for him, started him on a small dose of gabapentin. I used Grelise, the long-acting medication. He just sent me a text today. He said he's back to surgery on Tuesday next week. This is in a matter of, I only did 3 injections. I have not done a lot, but that was an early case. So early interventions, if anybody gets to see this or you know somebody that's happening, quickly look for help and say, can you get this? If something can be done early, you're likely to get better results than if you hang around for a long time. And multidisciplinary approach, this is the best way to get things done, especially when the situation starts to get more chronic. All right? Okay, this is just a very busy slide, but this is because I just had a call today. One of my patients is having surgery today, and she's having a cholecystectomy done today. She's got crips, and the anesthesiologist called and said, hey, listen, what do I do? So I just told them, I said, you need to give some intraoperative ketamine, but this is an important thing for you to understand, that in your lifetime, you probably will need surgery sometime. I hope you don't, but if you do, it is to keep in mind that you need to have some kind of a plan. How do you kind of take care of that? Medication categories, I'm not going to go through this whole process over there, but anti-inflammatory medications are used. I use this more so in this high dose process over there. I use celecoxib or ibuprofen, but I give them very high dose. I don't like using steroids. Steroids are good, but not so good. So I use ibuprofen, which is actually quite cheap and quite easy to afford. 800 milligrams 3 times a day for 3 to 5 days, acts as an anti-inflammatory, helps you get your things back in control over there. Various neuropathic pain medications, you can go through the list over there, gabapentin, Grelise, whatever. And none of them are the best medication. Everybody can try whatever. Anticonvulsants, triliptol, levetiracetam, Keppra, whatever. Muscle relaxants, this is actually quite beneficial because dystonia is a big problem with patients over there. So using a drug like baclofen helps a lot. Calcium and sodium channel blockers, anxiolytics, antidepressants, calcium channel blockers. Calcitonin. Calcitonin is an interesting drug which I use quite extensively. It's a nasal spray, and it helps with this anti-hypoanalgesic effect over there. Why? I have no idea why it works, but it works and it doesn't have any side effects. Now, opioids, not the preferred choice of drugs, but in an acute situation, yes, you would do that. But what you have to understand is that we talked about this central sensitization. Opioids will actually cause further central sensitization by activation of the glial cells. So you really don't want to use that if you're having a lot of neuropathic pain processes. This is a big issue. Short-acting opioids may benefit patients over there. Now, we're talking about interventions. Stellate ganglion nerve blocks is something that you do in the neck for people with upper extremity CRPS. It is done around that C6 vertebrae over there. You do it under fluoroscopy. There are a lot of blood vessels around there, so it needs to be done by somebody who knows what needs to be done over there. And I recommend this 2 times a week for about 2 to 3 weeks, and this breaks the pain cycle. Once the CRPS has been around for a while, it's really not helpful. Now, Exparel, this is a drug that's, bupivacaine is a local anesthetic, and Exparel is how it's delivered, and it's a long-acting local anesthetic, lasts for about 3 to 5 days. Now, this got approved actually for use when people are having hemorrhoid surgeries. You know what hemorrhoids are, right? That's a pain, where, sorry. But I use this for people with CRPS because it gives you a block for 3 days. So when people have long-time block over there, they are so much more encouraged rather than just for a few hours. So that's how a stellate ganglion block is done. You can see the needle over there. This is the C6 vertebrae. You can see the rib coming out over there, clavicle. And this is the contrast that goes into that place over there. And, when you get that, pretty good relief. The same thing happens with the lumbar sympathetic plexus block. This is for the lower extremities over there. I usually tend to put 2 needles, same thing. I like physical therapy to be done at the same time. And that's what you do. You get 1 needle coming over here, 1 needle coming over here. This is L2, this is L4. Put a little bit of contrast, and you put a lot of local anesthetic. So let's talk about the other two things that I do in my office, which are actually quite interesting. Naltrexone. Anybody over here on naltrexone? Low-dose naltrexone? Nobody's taking? Yeah. Two. Couple of them. Three. So low-dose naltrexone is actually an interesting drug, and I've been using it for the last 5 years, and I am blown away. I've been doing pain management for more than 30 plus years, and this has come as a complete wow. Naltrexone is a pure mu receptor antagonist, and for people who are using it know that this is used for people when you have an opioid overdosage. That's what you use. It's been around since the 80s. It's now approved for alcohol and opioid addiction, available as Vivitrol. Please don't confuse naltrexone and Vivitrol. Please don't confuse Contra with naltrexone that we're using, okay? Now, how does it work? It's usually administered at about that dose we start with. It's a compounded medication. The way it works, and I explain this to my patients, that when you give a prescription drug like naltrexone, it comes and sits on the receptor. And when you take heroin, naltrexone prevents the heroin from working on that receptor. But when you give it in a small amount, the naltrexone gets washed off. That receptor now is inducing the brain to release endorphins. And those endorphins are what are your natural painkillers. That's what happens over there. It acts, that's the central sensitization what we're talking about. And this is a technical term, TLR receptor. It's called toll-like receptor. The Germans were kind of doing research over there, and they didn't know what to say, so they called it toll, so that's why it's called toll-like receptors. But anyways, so this is part of the central sensitization process, and when you give naltrexone, it actually reverses that process. So when you give a lot of opioids to patients, it causes central sensitization. You're able to kind of reverse that central sensitization by using naltrexone. In addition, it blocks the production of a cytokinin. This is cytokinins are chemicals that cause swelling. It actually acts as an anti-inflammatory, so it's very useful. And this is the best thing that happens over there. It causes an enormous amount of boost in your T cell count, which is what the immune process that we know is involved in CRPS. So we've done about 450 patients over there. It's been very successful, 70% response rate. Response in a week, month, 3 months. This is something that's important, that it might take a few months before you see the response over there. I've had people who've been on prescription pain medications for 25 years. We've stopped them over there. I've had patients, intrathecal pumps I've removed over there. Really no side effects to worry about. Sometimes people have a headache, which is common enough. Sometimes they can't sleep. And it costs about $15 a month. So I'm sure the pharmaceutical industry is very upset with me because now I've taken away a lot of business with them, you know. Ketamine. This is the other thing that I do in my office over there. Now, anybody over here has had ketamine infusions? Wow, pretty big amount. Okay. Ketamine is an anesthetic drug. It's been around since the 1960s, okay? And if anybody knows what ketamine is, it's the cousin for angel dust, PCPs. So it's a hallucinogenic agent, okay? So when we started using it, I've been doing anesthesia since the 1980s, so I've used ketamine extensively. But it's a pretty good drug. It's very safe for cardiac and respiratory systems over there, but it has many side effects, okay? These are all the side effects that you have in ketamine. Now, what happened with ketamine since the 1990s? This is a gentleman, Graham Correll, is the one who initially introduced ketamine in Australia. He came to the USA, talked about it to Ron Hubbard, who then came and spoke to Robert Schwartzman. So even though Schwartzman gets a lot of credit for the ketamine, it is not him who initially started it in the US, it's Ron Hubbard who started it. But you know, Robert Schwartzman really popularized the process. Done outpatient, inpatient, ketamine coma, not recommended, not done in the USA. I have one patient of mine who went to Germany for a ketamine coma, and you know, she did well, but then the symptoms all came back. It requires supervision, you need to be monitored. All right? Now, this is the usual process that we do for ketamine, history and physical, use the criteria for that, no investigations, evaluation by cardiologists, psychologists. Presence of severe psychological issues don't do it. I had one patient who came to me and the psychological evaluation was done by somebody who I didn't know who the psychologist was, said, it's okay. I gave her ketamine the first time, second time, third time, I get a call from the police station. She's sleepwalking. I said, that's not such a good thing to do. And she's going home and she's sleepwalking on the streets. I said, okay, maybe one time. I did it one more time. Again, I said, okay, no more ketamine. I can't have this woman getting driven over by a truck because she's sleepwalking. So I stopped it. I mean, that was a bad thing for me. Okay, we like to perform all your SMSCs and LFTs before we do that. This is our outpatient setup over there. We have all the resuscitation equipment. What has been our protocol? This is the protocol that we use, which is what was set up by Schwartzman. It's been pretty good, not a problem at all. And 5 days, 2 days, stuff like that. Okay, now what we have had is we have been able to modify the technique because we can add lidocaine if we think it's helpful. We add magnesium. Some people have had a lot of success with IVIGs. We have added bisphosphonates. We've also added acetaminophen. Acetaminophen given intravenously is a powerful anti-inflammatory, and it's been pretty good. So what has been our experience in 7 years? We have done about 100 patients and about 2,700 sessions. And these are the drugs we've used over there. And these are the side effects. We did a little retrospective studies, analysis. And the only thing I'm going to tell you about this whole thing was that the PGIC, which is the patient's global impression of change, was 4.65. This is on a scale of 0 to 7, where 7 is complete resolution. So that is about 65%. And inpatient protocol is a lot more difficult. I don't do that. It's not recommended, but you can do it for 5 days at a time. Physical therapy. I don't know if anybody's speaking for physical therapy today. All right. Physical therapy is mandatory in the management of complex regional pain syndrome. If you're going to a doctor and they're not recommending physical therapy, ask for physical therapy. And hopefully you can find a physical therapist who knows what complex regional pain syndrome is, because it's not, the treatment is not the same like for regular people who have had back surgery or limb surgery or whatever it is. So just be careful. But it is really, really important that you start it, and you must continue with it as long as you need. Some people with CRPS need physical therapy for years because you need to maintain their function. But it is important that you do this. Multiple modalities are used for this process over there, and that is what you're looking at, is to maintain function. I had this patient who came to me from Delaware. She had a total knee replacement done. They didn't send her for physical therapy. Her knee got fixed. So they went back and they took out the old knee, put a new one in, and they forgot to send her for physical therapy. I said, you did it a second time, you didn't do that. So she came now in CRPS with a rigid knee, had an intrathecal pump in place. We kind of worked her out to try and see if we could help her over there. Finally, we took the intrathecal pump out on naltrexone. Now she's had stem cells put in after a third knee replacement, stem cells put into her knee joint. And now I can't control her pain because she does not respond to any opioids. So yesterday I saw her and I said, okay, let's try some oral ketamine and see if that makes a difference. And I don't know if it'll help or not, but it is really a significant problem that if you're not doing therapy at an early stage, you're going to have problems over there. Other options, we talked about the stimulator. There are other types of stimulators that are available in the market right now, and there's a choice that you can think in terms of. Intrathecal pumps, I do a lot of them, but I don't think this is going to hang around for CRPS. Thank you very much. I think I took too much time.
Dr. Data will be around today, so you could catch him. Next, I'm going to introduce you to my road partner. Often I take the ferry over to Long Island, and Beth Cycle and myself will go on a radio show. We had the pleasure of going to the American New York Association of Pain Management Nurses, and Beth is a RN, and she's an emergency department nurse, and it's really fabulous when you could go to a professional meeting with someone who is of the same discipline. And it was extraordinary when Beth, in a gentle but firm way, said, the way you treated me was not the way to treat me. And so over the years, Beth has worked with us to devise a hospital protocol, and it is special care for people with CRPS, and we try to make it available for everyone. And we're also developing one, and we have one for emergency departments, because for emergency departments, it is hell for a person in pain, especially in this opiate-phobic relationship now, for someone to go in. So Beth is going to talk about her toolkit for living with CRPS. Beth Cycle.
Okay, first of all, I just want to tell you, I do change colors, I do molt, I take my shoes off, and I move around a little bit, so don't get nervous. Is it on? Okay, can you hear me? Okay, the reason I call it a toolkit, can you hear me? The reason I call it a toolkit is because I had to come up with a way to take care of this condition. And even though I was an ER nurse and an ICU nurse and a trauma nurse, I had no idea what this condition was. It wasn't until I was diagnosed that I found out about it and started my own journey. So this is going to be the light and airy part. Okay, I just want to say that I am a volunteer of RSDSA. I am not getting paid for this, and I come from a different perspective because I'm also a nurse, so I look at things in a different way, and I know how the medical community is looking at patients. So if there's some things that I have done that might be helpful for you, that's my goal for you, but it's really just educational. And what works for me might not work for you, but it might. Okay, about Nurse Beth, the person. I've been married for a very long time, and if it wasn't for my partner, Glenn, down there, I wouldn't even be here, because driving I can do locally, but I don't really do long-term driving. So he's a wonderful person. I have 2 wonderful children, but I do have unique perspectives, and I think when you're living with anything that's chronic, such as CRPS, you need to develop a really good sense of humor. I already had a good sense of humor because I'm a nurse, and boy, could I say a lot of funny things about that. But now I'm the funny one. Nurse Beth, the patient. Well, I will say, and for the medical professionals here, we don't like to be patients. If you think you don't like to be patients, well, we really don't like to be patients. We like to have that sense of control. To be the one that now needs the support is a little difficult to do. But I was working, and I fell on a wet floor. I tore my ACL in my left leg, and I thought, okay, no big deal. It's a little inconvenient. Have a little surgery, a little PT, and then, go on your little way. But in the recovery room, I knew something was not right. I had so much relentless, persistent, non-explainable pain that all I could do was scream. And I went from a little ambulatory procedure to now I had to stay in the hospital for 5 days on a pain pump. And I can tell you that nobody understood what was really happening, but I knew something was wrong. It still took me, even though I can articulate and say to physicians and practitioners, I'm feeling very like neuropathic. I can feel these electrical sensations in my leg. I know that's not post-op. It's feeling like there's things crawling up and down my leg. I know that's not post-op. And it still took me 6 months to get diagnosed. But I do feel lucky because for a lot of people, it takes almost years to get diagnosed. So 6 months wasn't so bad. I did develop type 2, which just means that I had a documented nerve injury. I did go through that lovely EMG study. So if you've ever had that, that wasn't pleasant. It was really painful on my unaffected leg, but when they did it on my regular leg, I said, so when are we going to start? And he said, Beth, we're done. So I knew I had a nerve injury. And over time, I thought, now that I have a diagnosis, now I have a plan. But that's when I had to start educating myself. That's when I reached out to actually Jim many years ago. And here I am, a critical care trauma nurse. I know about trauma. I cried to him for about 40 minutes, and that started my journey with learning. I realized that I had to become the CEO of my own health. And I had to educate myself so I could then educate people in my team. So I just want, for those who do not have it, to imagine this. Imagine that your skin is so sensitive that a hug is painful, that putting bed sheets on is painful, wearing shoes, which is why I'm usually barefoot and in flip-flops in the middle of the winter, is painful, that you can actually have pain from sitting in a car from vibrations, which I will say is not as bad as it used to be, but that's just not normal. My son is a musician, and I'd go to his concerts, and I'd smile like, this is wonderful. But it was so painful when that bass drum started hitting around. I was just like, how could that be painful? And feeling like your skin is ice and fire. Logically, does that even make any sense? How could your skin feel hot and cold at the same time? So here's where my comic relief comes in. I saw this which will be relatable to a lot of people. You start really good, and you feel like, you know, okay. And all of a sudden you go, I'm going, okay, I'm done. I have to end this activity. I can't do it anymore. This was funny because when I've gone to the emergency room, as I've talked to many of you, and I have a list of all the things I'm on, I keep thinking to myself, if I could just put it all in one pill and be done for the day, that would really be good. And this one was good. I've actually had people say to me, so why are you so tired? And I said, well, you know, I'm having a hard time sleeping. And they said, well, just go to sleep. And I thought, oh, what night did they get that one? So when all these odd things happen, and I'm going to show you because Nurse Bet's very visual, I like you to see things because you can't always believe it. I feel like I'm in a Seinfeld episode, so I speak in the third person. This is what Nurse Bet's going to look like, because I still almost can't believe it. But I've developed skills. And you think, what kind of skills? Well, I can now turn blue. And it's not like I'm thinking it, it just automatically happens. I turn blue. It almost feels like my feet, because I have it mainly in my left leg, is in the Arctic Ocean, and I've turned into this glacier. I can turn red, and I can exactly remember the date I turned red. I was actually in the hospital, and I went from that blue kind of cyanotic dead foot look to this bright red, and I thought, what the heck is that? But it feels like molten lava. It almost feels like I have these skills that I could light a campfire. The best is I can turn red and blue at the same time. And every time it happens, and my husband will attest to this, I'll say, can you believe it? Just look at this. How is this even possible? That you could be burning hot here and freezing cold like a dead foot. I still think that's the most amazing thing ever. The best is the brain fog. I almost feel sometimes when it happens like I'm a vending machine and I put the money in and nothing came out. So if you have this condition and it happens, that's okay. I lose my train of thought all the time. I actually can turn shiny. It doesn't happen all the time. And I remember the first time it happened, it almost looked like did I come out of the shower and not dry my arm? Like, how could I possibly be shiny, like a wax floor? And when we did the walk in Long Island the first year, I had made a lot of educational boards that you'll actually see outside. And this mother was looking at this picture, and she started to cry. And I said, you know, what's the matter? She goes, my son, sometimes his skin gets like that. And I thought he was just being an obnoxious teenager, you know, flinging water on himself. I said, it is an amazing thing that can happen. I also developed these geometrical looking things. I almost look like a trellis. It doesn't happen all the time, but it's a skill. Okay, the best is, and you're going to see it because now the lights are going to make me red, my nose gets very inflamed. I could light the way, like Christmas. And I do get sometimes unusual swelling, almost like the hump of a camel. That's supposed to be funny. So if I had a magic wand, I would definitely share it with all of you after I use it first. But until I can find that magic wand, what do? I decided that I had to find a way so that I could get out of the house. So you should really be proud of yourself if you're here. It took me 8 years to get to an RSDSA conference. So you should really applaud yourself for just getting here. I had to decide, if I'm having issues at home, how am I going to manage this on the outside? And I know many of us have talked about that. How am I going to get out of the house? So I developed all these different toolkits for different things. And believe me, at the beginning, I never thought I could travel, and now I can travel. But I've done all these things in conjunction with a good team. And it does take a long time sometimes to find a good team. But always expect the unexpected and plan ahead. Okay, now, this is what goes on in my mind, so you can have empathy for my husband. But I'm always thinking, what am I going to need to get from point A to point B? So I have to think about the weather, and I think many of you would agree, I shouldn't have been a nurse, I should have been a meteorologist, because I do feel snow coming. Can't explain it. It could be a beautiful sunny day, but I can definitely feel it. But you have to think about what your tolerance level is, where you're going to go, what's the comfort level, what's the temperature. But have faith that you can do it with a lot of planning. So why do I have this toolkit? Well, because Nurse Beth needed to find a way to have some control over her life. And quite honestly, learning to let go of the fear of the unknown. I can't control everything, but I can control my own destiny. And by putting together some of these toolkits, which I'll show you, has helped me in many ways. For example, when my husband's been in the emergency room a couple of times, well, that wasn't part of my day. But if I didn't have everything that I needed, I wouldn't have been able to help him. But it has really improved the quality of my life. So who needs a toolkit? Quite honestly, anyone with a persistent chronic condition, such as I have asthma, so I'm always prepared with that, you should always have what you need. Why worry about it and not have it with you? This is key because a lot of times people will say it's not a real medical condition. It is a real medical condition. Okay, so what is a toolkit? They're just practical tools. Some of the things I'm going to show you, you might not need, but you might have things that I don't need. But it's honestly helped with the safety and my compliance of my plan. It does organize and it makes everything accessible. The worst thing to do is to be in that level of acuity, and you know what I'm saying right there, and you can't find what you need. That only compounds the whole stress in your body. It gives you confidence that you can get from point A to point B. And it honestly can build the communication with your doctor. Because if you have what you need, it helps expedite the conversations. So for example, you go to the doctor, and even Nurse Beth writes her list of questions because I don't want to forget. But I can bring out the medication bottle and say, listen, could you just explain this again? I'm really not quite sure when I should take that. Or I'm having trouble with this dose. Is there something else that we could do? Or maybe you can't take the pill form. Can we discuss, does it come in a liquid? Does it come in a cream? Can I do something else with it? It does help with the communication. But for me, it's like an umbrella. If I bring all the stuff, then I won't need it. But you know that one day you don't bring it, you're going to need it. So this is in my everyday toolkit, which I carry with me at all times. And yes, for men, and you don't know what it is, it's a makeup case, okay? There is no makeup in it, but it has things that I need every day. I might not need them every day, but I have them every day. The one thing I will say to you that's very important, especially for going into the emergency room, many times when you go to the emergency room, it's not because you're feeling good and you want a little massage. You can't talk because you're in a lot of pain. And so how do then you articulate to people, excuse me, I have this weird condition? You can't really talk. So what I've done is I've actually brought things with me. So for example, this might look like a lot, but that's my medication list. And the first time I did it, I didn't separate them into categories. I kind of just wrote them all together. And I remember a practitioner, we'll just leave it at that, who picked it up and said, you're on way too many meds, and gave it back to me. And I'm thinking, oh my God, I'm just here for some relief. Why do you have to antagonize me for? But then I thought, you know what? I'm going to change this up a little bit. I'm going to write all the meds that I take every day, all the time, including my asthma meds. I'm going to write here meds that I take PRN, meaning, you know, as I need it, might not need it every day, but I'll put it there. And these are my nutritional supplements. Why? Because if your nervous and immune system is hyper-functioning and it's working too hard, not because we're telling it so, it's just what's happening, then I need more than a multivitamin. I need something that's going to be more nutritionally healative to me, not curative, but healative. I bring that in. I also put up here the different diagnoses that I have and all my doctors, because that brain fog sometimes hit and I can't remember the numbers. I also bring in the hospital guideline. What I have started to do, because I was recently in the hospital again, is I actually do it in orange. Why? So when it goes into the chart, it doesn't get lost with all the other white papers. If you put it with orange, it does draw a little bit of attention to that. I also carry, which is here, and I know it's in your little bag that you got today, tips for managing complex regional pain syndrome. Now, I just want you to know, the goal for me doing this is not so every practitioner knows every little detail, but I find it validating to bring in things that are from RSDSA. I also carry that little card that says I have CRPS. It's very validating. It really provides, in a very short period, a little education about it, about what it is. I've appreciated that when I was in the ER and patients came in with conditions, I had no idea what they were. And they brought in a little information. I'm like, oh, thank God, at least I can get a little information from that. I also, in my list here of meds, having my daily meds, but I also have meds that are from specialty compounded pharmacies. For example, the low-dose naltrexone and my ketamine. They don't come from regular pharmacies. They're compounded special pharmacies. Okay, so to be funny, because I have to be funny a little bit, you could walk around with a big tool belt on you and put all your meds in there, but honestly, it's not comfortable and it doesn't go with anything you wear. So I decided to do my toolkit. However, for the men in the room who don't walk around with a handbag, you could always use the fanny packs. This is me at the walk at Long Island this past September, and someone should have said I looked like the Great Pumpkin. They should have said something, but for me, I knew that I had certain emergency meds and my EpiPens, so no matter where I was at the walk or who I was talking to, I had control. And there are packs that I have that you can get that also have like the cool packs in it. So for example, my low-dose naltrexone, I use it as a liquid because I could not tolerate the pills, and that needs to be refrigerated. And my ketamine troches, which I'll show you if you'd like to see them, when it's very warm, they need to be refrigerated. So that's why I use that. So some other things I do every day. Now, I say every day, it doesn't mean that I physically can do it every day. But I have found that I don't have arthritis, but I found some of the suggestions that they had from the Arthritis Foundation on modified yoga. Now, I know what you're thinking. You can't even stand sometimes. You can't even sit sometimes. What is Nurse Beth talking about doing yoga? Sometimes it's something I just did sitting in a chair, and it might have been just my arms moving. Maybe it was just a little meditation time. It's okay. Sometimes, just like what Jim said, before you have to move, and Dr. Dada, you have to move. Even if it's just your head and your arms, give yourself credit for doing that. So that's been very helpful. Flip-flops. I would love to wear my high heels and my closed shoes, but it is not possible. So I get a lot of looks when I go out, and I have my sleeveless, outfits on and my flip-flops. I do have a wheelchair and a cane. Doesn't mean I'm in that wheelchair all the time. I think the puppy's been very cathartic because on days that I've been really bad, she does get me out of that bed. This I want to point out. A lot of people have said to me, and it does make sense, if your skin is burning and it feels burning, it's similar to being at the beach. Now, I'm very fair, so I burn really quickly. What happens after you have a burn? Your skin gets itchy. So many of us who have the allodynia, the burning, have very itchy skin. So besides antihistamines, I found a cream that has been very helpful to me, which if you want to see it, I'll tell you off camera. But it's been very helpful because your skin's very dry and it can be very itchy. And I also always wear some kind of band. These are from the organization, but you can get a Mediband similar to if you have like a seizure disorder or diabetes. And I used to look at those when you came into the emergency room, because if you couldn't talk and you came in or you were unconscious and I had nobody with you and I didn't know what your history was, that was very helpful for me. Okay, one of the things that I do, remember I said that a multivitamin for me is not going to help. Why? Because my nervous and immune system is working doubly hard. So there was a great study that was done on vitamin C, and half the population didn't get it, and the other half with the wrist fractures did. And surprisingly enough, the ones that did receive the vitamin C did not develop CRPS. So for me, that was a win. I said, well, I can do that. And as long as your doctor says, listen, it's fine for you to take vitamin C, why wouldn't you take vitamin C? And I also, this is the vitamin C. I'm not advocating any one thing. I'm just showing you this is what I use. This is from a company, Melaleuca, and the reason I like it is because it's in powdered form, and because sometimes the CRPS does affect my GI system. I need something that I don't have to work very hard to break down, so I use powder. I also take calcium and D3 to keep those bones, even though I tell my kids I'm only 32, but you know, I need my calcium and my D3. But this is the powder blend. Some of you have been talking to me and asking me what I take. This is a prescription. I did not put the doses down that I have because everybody might be different, but I think this is something that would be powerful to talk to your doctor about. Simply saying, because most doctors don't know about this, simply saying if my nervous and immune system is working really hard, then a multivitamin is just not enough. How do I nourish that nervous system and immune system that's working so hard? This has given me energy. And you know, as Nurse Bet's a little doubting, I'm still have that scientific mind. How could this really help? So I stopped using it for a couple of days. And I was so weak. And I just felt, I almost felt like I had mono. I didn't have mono. But you feel like you have mono, that weakness. And then I took the mixture, sorry, that's not a good picture, and I mixed it with a lot of water, that vitamin C packet, and my whole powder blend. And I have to tell you, after time, I felt totally different. Do I still have the CRPS? Of course. But I feel healative. That mixed with the low-dose naltrexone in liquid for me, because I can't take the pills, has really changed my life. I would never, when I sat there like you are years ago, I thought I would never be able to ever share what I've learned. This has made a huge difference for me. I also did, and I'm not advocating any one thing, but I also put in a reverse osmosis in my home because I've noticed that I'm a little more sensitive, not here, physically I'm a little more sensitive to things in my environment. So if I can protect myself a little bit, I thought, what the heck, I'm going to do that. Okay. You didn't realize Nurse Bet's slides were going to be full of pictures. What do I carry every day? An umbrella. Why? Because sometimes, and think about it, if you had a sunburn, would you want to go back to the beach and sit in front of the sun? No, but that's how we feel. We feel like we're being burnt. I have to protect myself. So that is me. I'm sorry. My husband's actually building for us to go to the beach because I haven't made it to the water yet because the sand's a little noxious. But they do have these blue, you might have seen it. I'm from Long Island, if you haven't noticed. They have those blue pads that you'll see kids, and it's like a big PVC wheelchair, so my husband's making me, but he made it so large that 3 people could sit in it, so we need to just downsize it a little bit. But you can also go, this was us, my kids and I, at a play in Manhattan, and I thought, I can walk, but walking can be an issue, and if you have it lower limb, you know what I'm saying, so I do go in the wheelchair. Why? Because the more I stand on my feet, which you'll see, I molt and change colors, and then the flare gets worse. So why would I do that? I'm going to sit. They actually gave us a discount on the tickets because there is a accessible area. So just something to put in mind. And as you know, I had my TENS machine on for other issues, and I carry my heating pad for those dystonic, muscle cramps, which they are like giant Charlie horses that just don't end. So I find sometimes if I put it on that, it will help calm it down. And if you're wondering what this is, I was going to wear red today because I do turn red a lot. It actually is distracting to other people because then they don't realize that you're turning red. But I do have a raincoat that I found that has no sleeves. I do get a lot of looks, but it fits for me. Other things that I've done is a neck pillow because sometimes I just can't sleep on a regular pillow. And I am not gluten sensitive. I do not have an allergy. But I do notice that when I'm really flaring, if I lower my gluten, it does help. For those who have never tried it, I did bring a bag of those gluten-free pretzels, and we'll open it up. Tammy has them. We'll open them up and put them in the back if you want to try. If you have a soy allergy, though, don't eat them because they are soy-based. And be surprising or not, I have switched out pasta for my family, and of course told them, oh, definitely, it's regular pasta. Yeah, it's not. It was quinoa pasta or rice pasta. And when you put sauce on it and a whole lot of other stuff, as a mother, you smile and go, of course, it's regular pasta. How's your dinner? They don't know. They don't know. But that has helped. And I always bring my own towel. Why? Because when you go to a hotel, I don't know about you, but my skin's a little sensitive. I'm not using detergent, a towel with detergent that they use. And I always bring this soft blanket that I have. Why? Because I can't always lay on other people's sheets, because I use scent-free detergents, so this is how I've learned to accommodate. Okay, other things, we've talked about the flip-flops, and someone should really come up with really fancy flip-flops. I'd love to buy some. I go into adaptive clothing. Why is that? I wear lots of baggy things that are comfortable for me. You have to find what's comfortable for you. I can't really wear long sleeve shirts anymore because it becomes a little noxious, so I wear a lot of sleeveless things. There's those medications that I mentioned to you before, the low-dose naltrexone, and I just want to say that's it in liquid. I did try the low-dose naltrexone as a capsule, and I didn't do well with it. And I thought, maybe it's the dose. So I tried a lower dose, and I still just didn't do well with it. And then I said, Beth, think about it as a nurse. If you had a patient who wasn't doing well with these meds, what would you do? I called the pharmacy, and I said, does this medicine come in any other way besides a pill? And he goes, of course it does. It comes in liquid, it comes in cream. And I said, can you make it in just distilled water, so that I will know if I can really tolerate it or not? He goes, yeah, no problem. So I started it in a very low dose, non-therapeutic, meaning I knew it wasn't going to help. But my goal was long-term. If I could get this to help those screaming glia cells, and there's a picture out there, then I thought, what, that's taking some control back. So don't be frustrated if you ever try low-dose naltrexone and maybe you're not doing well with the capsule. You can use a liquid. Don't be frustrated if the dose you start doesn't work. You can slowly go up. It's the long term. You'll eventually get there. And so how did I balance those flares that I had while I was doing the low-dose naltrexone? Those ketamine troches. It's sublingual, and it works on another receptor, and there's a picture outside. And these two things, along with that vitamin compound, have totally changed my life. Okay, so traveling. How do you travel? You're going to get to know the TSA agents. And I will tell you, it takes a lot of planning, but it can be done. This is a notification card that you could print out, and I actually wrote whatever, where I have it. When I go to the airport, I wear baggy clothes. Things, and if you have this condition, you know what I'm saying, things I can pick up so you don't have to touch. It's the ugliest outfit, but it doesn't matter. And I will call ahead and say that I need somebody to get me through security. Why? I do have my husband, but he takes care of all my medications, the backpack, I bring everything with me. I want someone to get me through the line. I don't want to wait on the line so someone can hit me. And that's been very, very helpful. This is also a freebie for you with any kind of disability. This is a free pass. And I felt a little uncomfortable when I first did this because I thought, I don't need that. But then I thought sometimes, how many times do you go someplace and you can't stay very long? I thought, you know what? I'm going to do this. And we use this for Muir Woods, right? We went to Muir Woods, and I couldn't get through the whole thing. But you know what? The fact that I didn't pay for it and it was free kind of worked for me. We've mostly traveled on JetBlue. They have a lot of accommodations. In fact, I will take the wheelchair, my wheelchair, down to the plane, and when we get to the plane, I will walk in. I take off the legs and the the footrest, because sometimes they just suddenly get lost. And then my wheelchair goes into the cargo bay. Always keep your medicines with you at all times. Do not pack them in a suitcase. I do, because you could see I'm a little shy, but I always ask for accommodation. This was a vineyard out in California. Now, I can stand. This will be my standing for the day, and then I have to sit. But then I thought to myself, when you go to these vineyards for wine tasting, mostly those high bar stools, I can't sit on those. They're not comfortable. They actually had a little accommodation to wheel right in. I don't know who this man is, but this was a conference in California. And again, I can walk, but walking's an issue, so why would I torture my body? I went in the wheelchair. This was interesting, and when you're at the airport and you're going to rent a car, I've always wondered, how do I get from the rent-a-car to the car? Because most times they just give you the keys and you gotta go. This place actually in California had a shuttle system, which a ramp, what a novel idea. The ramp came out so the wheelchair could go on. My recommendation is always having your medical documentation. Why? It's empowering. It tells you what you have and what you need. And always bring some extra medication. Adapters, I did go international once. I went to Rome. It wasn't in the way that I wanted to go, but I did go. I will say, if you bring a wheelchair, get all-terrain wheelchair, because the bumps in Rome was a little challenging. The last thing I'm going to talk about is being in a hospital, what you can do as a patient in the hospital, things that are available to you. Many of us with allodynia, we're very sensitive to things. Not here. Our skin is sensitive. You can ask for hypoallergenic materials. For example, the EKG leads, those things are so sticky on your skin. Can you imagine having a burn and someone ripping those things off? It almost feels like your skin's coming off. So I use hypoallergenic leads. Paper tape is less noxious than that other tape. You can ask for hypoallergenic sheets and linens. Why? In a hospital, they use strong detergents for obvious reasons. It's a little noxious. I asked for disposable washcloths. You don't have to rinse with them. I do have these, so if you want to see what they look like and touch them, you can bring them. And for me, I bring a portable fan, because if it's too hot, I don't do too well. Here, you can ask the nurse to put a sign above your bed. Please do not cover the patient. Okay, now, I really wanted to educate you, and that's why I put the picture up there. It's not Nurse Beth looking her best. But I used dark sunglasses, even though I was in a room with no lights. Think about it. If your skin is already noxious, it doesn't take many more triggers to make your body noxious. So I found that those were very helpful. The soft blanket, I can't use that white part, but the velvet part was very helpful to me. And here, I had multiple IVs in one arm, so after they stick you multiple times, I was like, it's closed. Let's get to another plan. So they put in, it's called a midline pick. It's just a small IV that does not go into your heart. But then it saved me from being stuck again for more bloods. So it was like a miracle. But plan ahead to avoid obstacles. This is a list of what I go through before I decide what kind of toolkit that I'm going to bring. But most important, know that you can do it. Know you're not alone. These two things are very helpful. Insight is a free meditation device. Even if you do a minute, give yourself credit for doing that minute. And if anyone wants to communicate with me, my email's here, and I'll certainly give you my cell phone privately. Thank you. That's it, I'm done. Time for questions, or? No. Okay.
We're going to have one more speaker, and then we'll have a short break. I was just being interviewed by, if you're in Connecticut, Channel 12, so hopefully there'll be some publicity about our meeting today. One of the more exciting things that's been happening across the land in the last few years has been medical cannabis. And we have two speakers today, and one will be talking more about the history, safety, and efficacy of CRPS, of medical cannabis for neuropathic pain and other types of chronic pain syndromes. And he's a medical doctor, and he is chief medical officer of a New York-based company called Vero Health of New York, and he'll be talking Dr. Richard Drama. Please welcome him.
Hello, everyone. Stephen Dahmer. It's okay. Pleasure to be here. I actually met Jim through a patient, Stacy, and I attended the walk and learned more about CRPS on a Saturday walk than I did in most of my medical school education. Similar to Nurse Beth, it's not something we're taught about a lot in medical school. I am a board-certified family doctor. That has been my day job for over 10 years, and it's only been the last 2.5 years that I've been the chief medical officer of Vero Health. So the first time in my career, I'm biased. I work with a company that grows, produces medicine, and distributes medical cannabis in Minnesota and New York. So take my talk with a grain of salt, but in my heart, I'm a family doctor and just am absolutely moved by what I've seen with medical cannabis. And so when I get the opportunity to share that, even across the border in Connecticut, I'm happy to do so. First thing I ask, and being a family doctor and my background is in integrative medicine, I've dealt with stigma quite a bit, but I've never seen so much as there is with medical cannabis, or what many call marijuana. You can imagine what this term brings to light for most patients and providers when we speak about this are a lot of words that aren't so pretty and things that we don't like to talk about. When I give my talk, I just like to call attention to this. Let's take a step back and let's treat this potentially as a medicine from an objective viewpoint. And I just told you that I'm biased, but I'm going to try to present an objective viewpoint about this as a medicine. And this is a quote from not the most medical context in the world, The Economist, but really puts a lot of things together that I've seen in the last 2.5 years as I've studied thoroughly medical cannabis and learned a lot more about this. If we were to suddenly discover this in some remote mountain crevasse, this would be hailed as a medical breakthrough. It's really amazing the number of diseases that this can treat and the endocannabinoid system that it harnesses, which I'll talk a little bit about. A little bit of a historical background. I've done a fair amount of work in ethnobotany, mostly in Palau in the Pacific Ocean, but never have I seen a medicinal plant that has such an intimate relationship with us as humans. And it's just an absolutely fascinating plant. This is a plant that has more than 60 unique compounds. Those are, chemicals that within this plant that exist nowhere else, that have a unique ability to alter biochemistry in human beings. And there's more than 500 of them in this plant. The one that we all know about is THC. I'm guessing everyone here has heard of THC. And THC is one of 2 major cannabinoids, right, within this plant. As I said, there are 60 plus cannabinoids as well that most of us know because it makes you high or it's intoxicating. And what we don't talk about are all the other chemicals that are present in this plant. The other major cannabinoid is CBD. How many of us have heard of CBD? And again, I've been doing this for about 3 years in my career. When I asked that question 3 years ago, maybe 2 hands went up. And so things are certainly changing. CBD is a major cannabinoid that's non-intoxicating. The theories and in vitro studies show an anti-inflammatory effect, and we use it, and has gotten the most press for treating epilepsy in children with intractable seizures. Medical cannabis dates back, as far as 2900 BC, some estimates more than that, but so this has been a rich part of our pharmacopoeia for thousands of years, and utilizing it as a medicine as far back as 2700. And again, there are different estimates with that. But many call medical cannabis the Canis lupus familiaris of the plant kingdom. And like dogs, it's followed us all over the world. And the reason being not only for its medicinal benefit, but also its nutritional benefit, high in omega-3 fatty acids, and using the fiber. So the fiber is utilized in textiles and in many different areas, and it's a plant known as weed because it can grow in areas where weeds grow, grows very quickly and can be utilized in many different ways that are advantageous to us as humans. So in medicine, amassed by many physicians, well, we have THC, right, already present in medicine, and this is Marinol. If anyone is familiar with this, this was FDA approved 1985, I think, for nausea and vomiting related to chemotherapy. But the difference between this and what I'm speaking about today, which is a whole plant extract, is this is a single synthetic biochemical agent. So it's a synthetic THC. Again, THC being a phytocannabinoid that's produced by the plant that interacts with our endogenous system, but this is a synthetic form of it, and only one cannabinoid of these multiple cannabinoids that are present in the plant. One of the main reasons that this hasn't been utilized so much in medicine commonly is a high rate of adverse events. And this is debated, but certainly it's something that anyone that's utilized this medicine in their practice has seen that most patients don't tolerate this very well, and especially at the dose that it's recommended at. One of the things that is being argued, and this is debated, but is the thought that these multiple cannabinoids and the many other chemicals present in this plant are going to have a very different therapeutic effect within the human body. This has been termed the entourage effect, or which is a fancy term for synergy. Synergy is that thought that the whole is greater than the sum of the parts. So if you try to pick out one little piece of that, it's not going to have the same effect as many of these chemicals together. And what fascinates me about this plant is this idea of in the human body, when we talk about health, is homeostasis. And even these two major cannabinoids that we discussed, THC and CBD, have a natural antagonism. So within the same plant, the two major components antagonize one another. And so we know of THC that it can produce euphoria. In higher doses, it can trigger anxiety and even psychosis, cognitive impairment, and a rapid heart rate. And how fascinating that this plant that has co-evolved with us for tens of thousands of years within that same plant has a major cannabinoid that has the opposite effects, which are no or less euphoria, anti-anxiety, antipsychotic, neuroprotective, and bradycardia. And the thought is, and there are studies that back this, and I'll try to get into this a little bit more, is that loss of antagonism, meaning if you just pull one of these out and treat the human body with it, will lead to increased side effects and poor tolerability. And this is just a list of some of the other chemicals that are present in the plant. It's a pretty smart plant to create everything from cannabinoids to minor cannabinoids, terpenes, carotenoids, fatty acids, sterols, vitamins, and triglycerides. And this is a slide of the endocannabinoid system. Everyone's heard of the endocannabinoid system. This is something in medical school that I wasn't taught about at all. And this is an endogenous homeostatic system that can affect diverse processes in the body, from bone stimulation to immunosuppression to anti-psoriatic, anti-diabetic, anti-proliferative. This is just a fascinating endogenous system that when we utilize phytocannabinoids, the cannabinoids that are present in the plant, it engages this natural system that already occurs in the body. And the endocannabinoid system is known and has been studied to be thermoregulatory, changing temperature within the body, regulation of perceptive, cognitive, and motor functions, suggested roles, synaptic plasticity, brain development, hypothalamic hormone secretion, analgesics, so release of dynorphins, and affecting blood pressure and heart rate. It's a ubiquitous system that's present in the body having multiple effects. And we talk about pain, right? I mean, what a fascinating system of how pain works. And, and the little that I do understand of CRPS is the unknown etiology. And there are many things in medicine that we don't know, but we try to approach these from an evidence-based model and finding things that do make sense in the treatment. And we do know, in terms of the endocannabinoid system and pain, that there are similar locations to opioid receptors. That's periphery, the sensory neuron transduction pathway, and the descending modulatory pathway, with one huge difference, and that's an absence in the brainstem, which for us as physicians means that it can't shut down breathing. And that means that the side effect of potentially dying during sleep is not present with medical cannabis. And we do know, as studies move forward and we elucidate the endocannabinoid system and the presence of endocannabinoids in our blood, that there are certain diseases that once were termed black box, or we didn't know the etiology, that potentially could be explained by a clinical endocannabinoid deficiency. And, top of this list is migraine, and that there was a study, a very fascinating study, where they looked at levels of endocannabinoids in the cerebral spinal fluid, that's the fluid that bathes the brain, and it was shown a statistically significant difference between migraineurs, those that suffer from migraines, and those that don't, with lower endocannabinoid levels. And we're starting to see more research related to fibromyalgia, causalgia, as was discussed before, PTSD, bipolar, autism, epilepsy, and neurodegenerative disease, of a potential endocannabinoid imbalance or deficiency. This is fascinating for me, that in this area where a lot of times we'll see at the dispensary, or oftentimes even my own practice, I'll see those patients that are intractable, right, that have tried everything under the sun. There's a potential etiology that hasn't been discovered and that we're deciphering. I'm going to talk a little bit about, in my experiences mostly in New York and Minnesota, and I apologize that I don't have much experience in Connecticut, but I'll talk a little bit about medical cannabis in the United States and New York specifically. But we're seeing a huge push. 28 states, 29 states now, over 2.6 million patients are using medical cannabis as a therapeutic option to treat their disease. And this is legally, right? So this is the tip of the iceberg. And there are additional states that have some aspects, and a lot are looking at CBD as a potential treatment for epilepsy and other diseases as well. I try to make it a little bit fun with pictures, so it's not all business once in a while. It's a gorgeous plant, and it's just we think of it with this negative connotation, but it really is an amazing plant to work with. In New York and Connecticut, anywhere in the United States, as providers, as physicians, nurse practitioners, physicians assistants, we can't prescribe medical cannabis. It's called recommending, because on a federal level this is still an illegal substance, and that protects us and our DEA number by not prescribing it, by recommending it. These are the qualifying conditions in New York. I apologize, I did look quickly at Connecticut, that there is certainly overlap between these, but these are severe debilitating diseases. And as I've been working with this for 2.5 years, in our dispensary I've had more interaction with CRPS patients than I have in my entire career as a family doctor. And that is because these oftentimes are the intractable patients that have tried everything under the sun and are using medical cannabis as a last resort. In New York, this was most recently added chronic pain, which you could imagine opens the door quite a bit for patients that can utilize this as a therapeutic option. In New York, you have to have a accompanying symptom as well. But these are some of the things that I think are key about a medical model revolving around medical cannabis, and that is that it's licensed pharmacists that dispense it, that it's extracted through CO2, which we think is one of the safest forms of extraction, that we have a formulation or a real dose. And this is one of the things that really got me involved in as a physician. In New York, we have third-party testing by the Department of Health that we have to have within 5% of that stated dose. So that means if we say there's 2.5 milligrams of THC and 2.5 milligrams of CBD, we have to have within 5% of that stated dose in order for that product to be able to dispense to a patient. Most medicines have a 10% window, so this is even more strict than most medicines will find in a pharmacy. And this is what I think is absolutely key, that if a patient comes and does receive some benefit, or even if they don't, to be able to titrate that medicine, and also to be able to give that same medicine if you come back in 2 weeks. And this is something that I think is a big difference between programs out west and programs in the east here, like the New York program. That's precision of that final product, that there is third-party testing. Anyone that explores medical cannabis as a therapeutic option should absolutely make sure they see third-party testing, that there aren't heavy metals, bacterial, fungal elements, that there are what's stated in that medication. And there aren't popularized names and strains, no advertising, and a number of conditions that are relatively severe that qualify someone. Anybody know what this is? Any guesses? This is a magnification of the flower bud of the cannabis plant. These tiny little balls here are called trichomes. These are the factories on that bud that actually produce the oil that is then utilized to make the medicine. So these little factories on the magnified bud here are where the oils are produced with all those chemicals that are utilized as medicine. There's kind of a magnified view of that trichome. And this is just a process of kind of what happens with cultivation, extraction, formulation of an actual medicine, that packaging and the distribution to a patient. And again, just talking of that difference, and it's not that I'm an enemy of programs out west, it just, as a physician, if I get Michael Phelps, that doesn't mean a lot to me. Or if somebody gives me a purple gorilla, I don't really know how to titrate that. I don't know if I'm getting the same product if I come back 2 weeks later to treat my very severe disease. And I want to know what's in there. And that's the idea of creating a medicine that has the milligram active cannabinoids listed on the side, that's third-party tested, that we know is safe. And to distribute in a place that feels comfortable. There aren't bongs on the shelves or neon lights, that feels like a doctor's office, and you can speak with a New York licensed pharmacist and discuss what might be your treatment regimen. And this is something that we've created, we call a spectrum, to make sense of cannabinoid-based medicine. And this means that we have varying ratios of THC and CBD, along with all those other chemicals and constituents I talked about. But there are differing ratios that treat different diseases. And as you saw the disease states, they're very different. Most patients will start in a green ratio, which is a 1-to-1 ratio. And an example is we create a capsule that's green and has 2.5 milligrams of THC and 2.5 milligrams of CBD. That creates a very structured backbone from which to either titrate up, titrate down, or shift. I think they'll be discussed a little bit more the science behind the treatment of neuropathy. Most of the science has been with THC, right? So a patient that doesn't respond to a 1-to-1 may move in that direction of a higher THC dominant strain. And again, coming in the form of a medicine. But this gives us a backbone to discuss medical cannabis in a logical fashion and titrate patients in a way that makes sense. And these are the forms that are allowed by law in New York, from capsules to a vaporized form, the benefit of that being a real quick onset of action. The capsule and the oral solution will have a slower onset of action but will last a longer period of time. And an oral oil that you can actually titrate very closely to 0.05 milligram major cannabinoid if you need to. And the major differences of these are onset of action and how long they're going to last. With the oral solution and the capsules lasting the longest, a lot of patients utilize this to not only alleviate their symptoms, but to help them get sleep at night. This is beneficial to take at night, as opposed to something, wow, I feel the snow coming, I need quick onset and need something to kick in quickly as a PRN, but it won't last as long. So to get on top of it with a longer acting solution. I don't know how much time I have. I've got way too many slides. I get really excited and I just keep going. This was actually developed by one of my mentors. I grew up in Wisconsin. Dr. David Rakel developed this. And in medicine, we're real excited about SORT and evidence-based medicine. And this is, what is the research that proves a medicine or a treatment is efficacious and it works in patient? And that's my mantra. I'm a board-certified Western medical doctor. That is my mantra as well. I think one thing we don't look at enough is the other side of that. And so Dr. Rakel created a kind of a schema that is the strength of evidence, or that evidence that something works, but also taking in mind harm grading, right? And so example is exercise and diabetes. There are a few that will argue this won't benefit a diabetic to exercise a little bit more, and the potential for harm is incredibly low. Opioids in chronic pain are falling much lower, as we're seeing there is tremendous evidence for harm, including death, and not very good evidence that they work in chronic pain. And this is something that I hope that we start to discuss a little bit more within the medical field, is looking at not only that potential for benefit, but that potential for harm. And these are just grades of evidence. I'll skip through these a little bit, but we should have those same levels when we're deciding, and I encourage all my patients to think about this as well. What is that potential evidence for harm when I'm weighing these therapeutic options? And as physicians, we're caught in the middle. We would love an alternative to opioids for chronic pain, but oftentimes there isn't that, and I can say that as a busy primary care doctor as well. When a patient reaches my door, oftentimes many of the over-the-counter remedies have been tried, and a lot of the other therapeutic modalities are now available. And so most people ask me, and physicians especially, will show me the evidence for medical cannabis in the treatment of pain. And I think we're going to have a lecture that goes into depth a little bit more about that. But this I recently submitted to the Department of Health. This is something that has been studied widely. And, everyone can argue about the levels of evidence, but, these are 5 of my highest quality randomized double-blind control studies related to medical cannabis and neuropathic pain. And so this evidence exists, and you have to look for it. This is a great study that was done by Donald Abrams, UCSF, that there is a synergy with opioids, right? That providing pain relief with lower opioid doses and less side effects without changing the opioid levels in the blood. This is kind of a little bit of a discussion. I'll skip over a little kind of quickly, but in the United States, usually more is better. And this is actually a fascinating study and something we talk about at our dispensaries. You don't want to just crank up the levels of THC. There is a sweet spot for each patient that's very different and very nuanced. And there's actually evidence showing that if we go too high, there's going to be an increase in side effects. So that's something that our pharmacists work with patients on, is to try to find that sweet spot. When you've gone too far and entered into side effects, then you've passed that sweet spot and need to come back. And this is something heavily debated, and there is evidence on both sides of the story here, but we certainly see this on a daily basis. We have a biased sample of patients that make it to our dispensary, but one of their main goals is usually to get off opioids. And this is just evidence done in 2016 that 64% of these patients did have a decrease in their opioid use, with 45% showing improved quality of life. And I certainly think right now cannabis is used as a last resort. I certainly think in the future we're going to be using this on all steps of that analgesic ladder. And I bet a lot of you are familiar with this and how we treat pain in the medical community. I think it's a tremendous adjuvant in many of those areas of the ladder. Anyone here familiar with numbers needed to treat? Numbers needed to treat, NNT. Yeah, this is something I'm a big fan of and share with all of my patients. In medicine, the numbers needed to treat are the number of patients that we have to treat for one to improve. And so it's not a number we talk enough about, and we're gathering more studies to have this. And there's actually a website called the NNT, and that helps us to put in context. There are some drugs that you have to treat 3,000 patients for one to improve, right? And this puts that in context of how many patients actually have to be treated with painful sensory neuropathy. Apologize for the capital Y, I'm not sure how that happened. This is from the AMA Ethics Virtual Mentor. And you'll see cannabis, it's right up there. The only thing that beats it are tricyclics with a tremendous amount of side effects. And this is what I start to get excited about as a board-certified physician as we delve into the research, and you see that cannabis stacks up with many of these other treatments that we commonly use and are even FDA approved for the treatment of these diseases. This is, again, very biased research. Apologize for this. These are the patients that came to our dispensary in Minnesota. So they have a severe disease, they went to see a provider, they got certified, they got their certification in the mail, they came to our dispensary, they paid in cash for the medicine. But of those patients that are intractables, 24 plus 66, 90% of them are mild to moderate to significant benefit. So 90% of our patients that are making it through this process are benefiting from medical cannabis. Pretty interesting. And then I'd like to talk, anytime I speak about a medication, there's a shadow side, right? And we don't talk about it enough, and medical cannabis has that as well. There are contraindications. These are the only absolute contraindications, which are acute psychosis, other unstable psychiatric conditions. There are relative contraindications I don't think we're talking about enough. Someone with a recent myocardial infarction or a heart attack should not be started on medical cannabis. Somebody with a severe history of arrhythmias, obviously someone in an ICU should not be started. But there are also a lot of cautions, and that include breastfeeding, pregnancy. Obviously, anyone under the age of 21, there has to be a real close discussion on risks, benefits, and alternatives for anyone under 21. And then drug interactions. And that's something that we're talking about more and starting to examine a little bit more, that there do exist drug interactions between cannabis. And that's why I think even more reason to have a medical model, to have health professionals involved, that a provider, your physician is involved in this decision-making process. And this is just a slide on the cardiovascular side effects. Again, if you have a strong cardiovascular history, you should very closely weigh the pros and cons of utilizing medical cannabis. But there are also great studies, a year plus and even longer than that, that show medical cannabis is an incredibly safe therapeutic option. And this is honestly, one of the big things that got me involved in this as a physician. And at our dispensaries, the mantra is to start low, go slow. And I talked a little bit about this sweet spot. So oftentimes, we are going to start at a dose where we expect a patient to feel nothing. And that shouldn't deter a patient, and the downside of that is cost, which I will get to here in a second. But we're going to titrate you up until there is that therapeutic window. The hard part about cannabis is that therapeutic window can be incredibly wide. A person my weight could benefit from 2.5 milligrams of THC or could take 1,800 milligrams of THC, and there's a wide range of that. But we try to creep someone up to that lower end of the therapeutic range and stop there. When we've gone past that, that's when you develop side effects. And one thing that's very interesting about medical cannabis, and I don't see with other drugs, is that this therapeutic range can widen as you're on medical cannabis as a treatment. And the body gets used to side effects faster than it develops tolerance to the medication, which is also a fascinating area of medical cannabis that I look forward to researching more. And this was, really what turned me as a physician. LD50, has anyone heard of that? LD50 is the lethal dose 50. It's mostly studied in mice, but it's a dose at which 50% of those mice will die. So it's a pretty hard stop that is going to kill 50% of the population, in that case mice, and we extrapolate that to humans. This is a little bit of a different graph where we put the LD50 over the usual accepted dose. And you'll see common things like codeine have a very minimal LD50 compared to medical cannabis or marijuana as it's listed here. And this is one of the things that really, piqued my interest, is that there's been no documented lethal toxicity from medical cannabis, meaning that a lethal overdose is impossible.
Why do you think the federal government's having issues with this? At a medical level versus...
That's a whole nother lecture. Yeah, no, there's a lot of reasons for that, and I try not to get into that. I just try to keep to that evidence, and we are utilizing it, and the tide is changing quite a bit. And I know we're getting short on time because Jim's standing up. The difference, in the brainstem, there are not receptors for medical cannabis. So a lot of what we're seeing with the opioid overdose, and even I think opioids are the tip of the iceberg. We don't talk enough about NSAIDs and the potential side effect of NSAIDs, that I think this is going to be a tremendous therapeutic option that we should explore and at least discuss at the table when we're discussing therapeutic options at our visit. And this is a talk of cannabis use disorder, right? And there is a 9% of patients, this is in an illegal model that this research was done, that have tried medical cannabis that can potentially develop addiction or a cannabis use disorder. So there is a shadow side, and we need to learn from lessons in the past and set this up in the context of a medical model and beware of those patients that might go on to abuse this. But cannabis does not kill patients. This is the main thing that really turned me as a physician, and now 2.5 years later to be doing this, is to see how patients are benefiting from this medication. It's been shown to be effective for the treatment of chronic pain, neuropathy with the highest evidence, very well tolerated side effect profile, works synergistically with opioids. And as the medical community, we should really be the first in discussing this and deciding whether this is an adequate treatment for our patients or not. Thank you.
Somehow Jeffrey Dahmer was in my mind. I apologize, Stephen. We're going to take a short break, and then we're going to come back and hear about the experience in Connecticut with medical cannabis.